So, good day everyone. Today we are going to discuss two activities, and these are clot retraction and clot lysis. So, these two laboratory procedures are actually evaluations of how well our body performs fibrinolysis once there is formation of a stable fibrin clot, especially when there is already healing. Okay, so now let's try to refresh our memory about the definition of fibrinolysis. So, this process is the final stage of the secondary hemostasis. Now, we have to remember that our fibrin clots are temporary structures that seal off a damaged area until healing can take place. Now, in the process called fibrinolysis, there is actually the removal of your insoluble fibrin deposits by enzymatic digestion of the stabilized fibrin polymer. Now, this process would happen few hours after fibrin polymerization and cross-linking would take place due to the activation of your factor 13 to its serine protease, which is factor 13A. This step is systematic and it accelerates hydrolysis of your fibrin polymers in the presence of your plasmin. So plasmin, that is the activated form of your plasminogen, and it acts upon your fibrin or fibrinogen, which would result to the production of smaller fragments we call as your fibrin or fibrinogen degradation products. Now looking at our illustration on this slide, so this is actually a fibrin polymer. So we can say that it is a fibrin polymer because if you try to look at the D domains of this structure, it is connected by a covalent bond due to the action of your factor 13A. And once plasmin is present in the degradation of this structure, it would result to the production of your D dimer and the other fragments. Now, let's try to look at plasminogen. So, plasminogen is a 92,000 Dalton plasma zymogen that is produced by the liver. Plasminogen bound to fibrin, it is converted to active plasmin in the presence of your plasminogen activator. So, inactive plasminogen circulates in the plasma until an injury occurs. The activators of plasminogen consist of either endogenous or exogenous groups. Plasminogen activation to plasmin is the result of the activity of a number of proteolytic enzymes. These enzymes we call as kinases are referred to as the plasminogen activators. Plasminogen activators are found in various sites such as the vascular endothelium or lysosomal granules, and they can also be found in biological fluids. At least two forms of tissue activators have been described, those that seem related to urokinase, which is a urinary activator of plasminogen, and those unrelated to urokinase. The activators unrelated to urokinase include your thrombin, bacterial products such as streptokinase from your beta-hemolytic streptococci, and staphylokinase. Plasma activators of plasminogen include also your plasma kallikrein, your activated plasma thromboplastin antecedents, or your factor 11, and activated H-man factor, or the factor 12A. So this is how your plasminogen activators convert your plasminogen to plasmin. So our plasminogen activators are produced by vascular endothelial cells during injury, and in the presence of these activators, your plasminogen would be activated to plasmin. However, the activation of plasminogen to plasmin um, is also inhibited by your PAIs or the plasminogen activator inhibitors. And then once there is already the presence of your plasmin, it would degrade your fibrin and it would result to your fibrin degradation products or your FDPs. And like your activation of plasminogen to plasmin, the breakdown of your fibrin to fibrin degradation products by plasmin, it's also inhibited by what we call your plasmin inhibitors. Next, we have plasmin. So plasmin is a serine protease that systematically digests fibrin polymers through the hydrolysis of arginine and lysine-related peptide bonds. Plasmin can be of two types. We have the free plasmin, which is bound to an alpha-2 antiplasmin, which is its inhibitor, and we have the bound plasmin, which is the plasmin attached to a fibrin. So digested fibrin, it causes exposure of the lysine peptide bonds and it binds additional plasmin, thus the clot digestion is increased. However, free plasmin or plasmin that is in the plasma, they are also capable of digesting fluid phase fibrinogen and factors 5 and 8. That's why free plasmin should always be bound to an alpha-2 antiplasmin to prevent this one from happening. So this is an illustration of how our plasminogen activators and plasmin inhibitors play their respective roles, especially in the breakdown of fibrin clots. So our TPA or our tissue plasminogen activator, um, it is bound to one plasminogen activator inhibitor, especially if the TPA is free in plasma. And then another TPA is bound to plasminogen because in the presence of your TPA, plasminogen will be converted to plasmin. And remember in the previous slides, I mentioned that there are two types of plasmin. The first one is the free plasmin, which is bound to an alpha-2 antiplasmin. So this should be the case all the time because if there is no inhibitor for free plasmin, plasmin would destroy the other coagulation factors. And then you have plasmin that is bound to fibrin. So the plasmin that is bound to fibrin is responsible for the clot dissolution, which would result to the production of your fibrin degradation products. So these are the components of the plasma fibrinolytic system. We have our plasminogen activators that are divided into two groups. We have the endogenous, and under endogenous activators, we have the TPA and the urokinase. And for the exogenous activators, we have streptokinase, staphylokinase, and the APSAC or the anisolated plasminogen streptokinase activator complex. For the plasminogen inhibitors, we have alpha-2 plasmin inhibitor or the alpha-2 antiplasmin and the tissue plasminogen activator inhibitor or the PAI-1. The first type of endogenous plasminogen activator is what we call the tissue type plasminogen activator or the TPA. This activator is secreted by the endothelial cells and its function is to hydrolyze fibrin-bound plasminogen and initiate fibrinolysis. Free TPA circulates in the plasma and they are bound to inhibitors such as the PAI-1 and they are usually cleared from the plasma. Another plasminogen activator is urokinase, and this is secreted by urinary tract epithelial cells, monocytes, and even macrophages. They circulate in the plasma at a concentration of 2 to 4 ng per dl, and they become incorporated into the mix of fibrin-bound plasminogen and TPA at the time of thrombus formation. For the exogenous plasminogen activators, we have the streptokinase, the staphylokinase, and the anisolated plasminogen streptokinase activator complex, or the APSAC. Now, streptokinase, this one is produced by bacteria, especially the beta hemolytic streptococci. Your staphylokinase, it is a protein produced by S. aureus. And your APSAC, this consists of plasminogen and streptokinase, which are bound non-covalently. So all of these are exogenous plasminogen activators. For our plasminogen inhibitors, we have the plasminogen activator inhibitor 1 or the PAI1. This one is secreted by the endothelium, our adipocytes, megakaryocytes, and hepatocytes. Their function is to prevent TPA and urokinase from activating free fluid phase plasminogen. They usually circulate in the system wherein one TPA is normally bound to a PAI1. So there is 1:1 ratio between your TPA and PAI1. If the body is deficient with PAI1, this is usually associated with chronic mild bleeding due to increased fibrinolysis. That is because there is no inhibitor for your um, TPA or urokinase. However, the opposite of this one is if there is excess PAI1, meaning to say increased inhibitors in the system, it could also be associated to thrombosis due to the reduction of your fibrinolytic system. Another inhibitor that we have is the alpha-2 plasmin inhibitor or the alpha-2 antiplasmin. So this inhibitor is synthesized by the liver and it is referred to as the primary inhibitor of plasmin. This is a plasma protein that rapidly and irreversibly binds free plasmin because if free plasmin is not bound to an alpha to antiplasmin, there is a possibility that the free plasmin would destroy your clotting factors. Another inhibitor is what we call the thrombin activatable fibrinolysis inhibitor or the TAFI. Um, This is activated by the thrombin thrombomodulin complex, and its function is to primarily inhibit fibrinolysis by preventing binding of the tissue plasminogen activator and plasminogen on the partially degraded fibrin, which would result to the formation of plasmin. Decreased thrombin production may reduce the activation of the TAFI, which would lead to increased fibrinolysis and bleeding of the patient. On the other hand, if there is increased thrombin generation, it would also increase the activation of your TAFI, leading to thrombosis or clot formation. So for the degradation of fibrinogen and fibrin, I think it has been reiterated many times in the previous lectures that our plasmin can degrade both fibrinogen and fibrin, and in the process of degradation, products are formed, what we call the fibrin or the fibrinogen degradation products. They are produced when plasmin degrades the fibrin or fibrinogen. These degradation products are removed by the liver, kidney, and our RES or the reticuloendothelial system. So again, this is an illustration showing you guys how plasmin degrades our fibrinogen and fibrin, resulting to the production of the fibrinogen or fibrin degradation products. We have here an illustration of the different activators and inhibitors of the fibrinolytic system. So the activators are indicated by the red arrows, while the inhibitors are indicated by the blue arrows. Now, all of these activators and inhibitors should work together to maintain or to achieve balance during fibrinolysis. So this table shows the list of inhibitors, naturally occurring inhibitors that are circulating in our system, and what systems are they trying to inhibit? Like, is it the coagulation system or the fibrinolytic system? So first we have the antithrombin 3, which can inhibit both the coagulation and fibrinolytic system. And antithrombin 3 has an inhibitory effect against thrombin, factors 12, factors 11, 10, 9, and even kallikrein. And for the fibrinolytic system, it inhibits your plasmin. Next, we have the alpha-2 macroglobulin. Alpha-2 macroglobulin is a plasma protein that is found in the blood and it's mainly produced by the liver. And also, it is locally synthesized by macrophages and fibroblasts. These inhibitor can inhibit both the coagulation and fibrinolytic systems. And for the coagulation system, it can inhibit the functions of thrombin and kallikrein, and for the fibrinolytic system, it can inhibit the function of plasmin. We also have alpha 1 antitrypsin. It is an inhibitor of the coagulation system. It is a potent inhibitor of factor 11 and a weak inhibitor of thrombin, and to some extent, alpha 1 antitrypsin was also found to have inhibitory activity against plasmin. Then we have complement 1 inactivator, which has an inhibitory effect against both fibrinolytic and coagulation systems, and it can inhibit plasmin, factors 12, 11, and kallikrein. Another inhibitor is protein C. This inhibitor has an activity against both fibrinolytic and coagulation system. So for the fibrinolytic system, protein C complexes with protein S to speed up fibrinolysis by inactivating inhibitors of plasminogen activators. And for the coagulation system, protein C still complexes with protein S to inhibit factors 5 and 8. Protein S, on the other hand, the same with protein C, it functions to inhibit the fibrinolytic and coagulation system. And this time, your protein S, it forms a complex with protein C to speed up fibrinolysis, and it also forms a complex with protein C to inhibit factors 5 and 8. Then we have alpha 2 antiplasmin. This is a potent plasmin inhibitor, which means that its function is against the fibrinolytic system. So now we go to the different laboratory evaluations for fibrinolysis, and we start first with the determination of the lysis time. The first procedure for clot lysis time determination is what we call the whole blood clot lysis time. So the principle behind this test is that if you try to subject your whole blood to a glass tube, or if you're going to collect your blood sample using a glass test tube, it would spontaneously form a clot without an anticoagulant. This is because if you try to remember in the previous discussion, if your whole blood is subjected to a negatively charged surface, in this case, a glass tube, the intrinsic coagulation pathway will be activated, starting with the activation first of your factor 12 until a stable fibrin clot is formed. So for the interpretation of this test, so normally, um, in normal patients, the clot should remain intact for 2 days or 48 hours at 37 degrees Celsius. And it is abnormal if prior to the 48 hours, there is already clot lysis or dissolution, because that would indicate that there is excessive systemic fibrinolysis. So the whole blood clot lysis test only detects grossly increased fibrinolytic activity, and the reference range for this procedure is that there should be no clot lysis after 48 hours, or the clot is still intact. When you perform this procedure, you have to make sure that the clot is inside the water bath for 48 hours at 37 degrees Celsius. So this is an example of a picture showing you guys how whole blood clot lysis test is performed. Um, if you have seen these tubes, there are formations of clots, especially in tube 1 and tube 3, 4, and 5. Now, looking at your tube 1, this should be the normal clot lysis result. The clot is still intact after 48 hours. However, for tubes 2, 3, 4, and 5, if before you reach 48 hours, the clot starts to dissolve, or the clot starts to lyse, that means to say that there is increased fibrinolytic activity inside the body, which is abnormal. The next laboratory evaluation for determination of clot lysis time is called the dilute whole blood clot lysis time and plasma clot lysis time. So these tests are modifications of the whole blood clot lysis time, and the principle behind this test is that dilution is applied, or dilution is made on the blood or plasma with a buffer. Usually the diluent is the phosphate buffered saline. And the purpose of diluting the blood or plasma is to minimize the activity of the inhibitors to plasmin or plasminogen. So if these inhibitors are decreased or minimized, plasminogen activators or plasmin that are free in the plasma of the patient will be able to lyse the available fibrin clot. Next, we have the euglobulin clot lysis test. So euglobulins are proteins that precipitate when plasma is diluted with water and acidified. And these euglobulins, they contain the plasminogen, plasmin, fibrinogen, and plasminogen activator. So the principle behind this test is that the patient's plasma is diluted with water and acidified to precipitate the euglobulin portion of the plasma, which contains the activators and inhibitors of the fibrinolytic system. So most of the inhibitors of the fibrinolysis remains in the supernatant fluid, which is then removed from the system. So once the globulins are precipitated from the plasma, they are dissolved in a buffer solution and allowed to clot by adding thrombin. So the time needed for complete lysis at 37 degrees Celsius is recorded as the euglobulin clot lysis time. The reference range for this test is that there should be complete lysis after 2 hours or more. But guys, the euglobulin clot lysis time, it's prone to many errors. First, prolonged tourniquet application. Application of the tourniquet for more than 1 minute can cause false positive results. And then if the plasma concentration of the patient is less than 80 mg per dl, or if there is a significant concentration of FDP, there will be a poor clot that will be formed, resulting in falsely shortened lysis time, which would mean that it is a false positive result. Other sources of error would be reduced plasminogen concentration, which is seen in some cases of DIC and which would give a false negative result. And then we have excessive agitation of the tube containing the clot, which would result to an erroneous endpoint. So for the interpretation of our euglobulin clot lysis time, there should be no lysis that will occur in less than 2 hours, because if that happens, that means that there is increased fibrinolytic activity. So we're done with the determinations of clot lysis time. Now we go to the determination of retraction time. The clot retraction test is a procedure that is used in the past to assess platelet function. So you are going to collect whole blood, and you have to place it inside a clean glass test tube and incubate the sample at 37 degrees Celsius. So you have to inspect for clot retraction every 1, 2, 4, and 24 hours. So after 1 hour, the clot begins to shrink or decrease in size and retract from the walls of the tube. The retraction process is maximal at 24 hours. For the clot retraction test, we have two known methods under this. The first one is called the Stefanini method, which is a qualitative method to determine clot retraction. So in this method, the medical technologist will have to collect a non-anticoagulated sample, which is usually collected in a red top tube, and After collection, an applicator stick or rod is placed in the tube. The tube is then incubated at 37 degrees Celsius, and clot retraction is noted after 1, 2, 4, and 24 hours. So every 1, 2, 4, and 24 hours, you have to inspect the degree of clot retraction. And for the quality of the clot formed, it is usually done after 24 hours. For the degree of clot retraction, this is how you are going to assess the appearance of your clot inside the tube. So if you notice that the clot has already reduced its size, and the clot detaches from the walls of the test tube, then it is described as complete or normal retraction. And also notice the amount of serum that is present in the tube. And then for the partial retraction, the clot starts to detach from the walls of the test tube, but there is only a small amount of serum that can be seen. And then for poor retraction, you can see that the clot has not yet detached from the wall or from the walls of the glass test tube, and no serum is seen in the sample. So this is how the clot would appear inside the glass test tube after 24 hours of incubation. So for a normal clot retraction, the clot would shrink and detach from the walls of the test tube. And if you try to look at the size of the clot, it's also small. But for the abnormal clot retraction, after 24 hours, the clot looks bigger and the amount of plasma is less, and the clot has not entirely detached from the walls of the glass test tube. So this is another perspective of the clot retraction test, and notice the presence of the metal rod that is placed inside the glass test tube. So after 24 hours, if you are going to interpret the result for the test, you have to look at the appearance of the clot that has retracted. You have to notice the shrinking of its size, and usually the clot would attach on the metal rod. Notice also the amount of serum that appeared after 24 hours of incubation. And then the other tube here, we have still the presence of your metal rod placed inside the tube. And then after 24 hours, uh, notice that there is no clot retraction that happened. Okay, as evident by no presence of the clot that has attached in the metal rod. Aside from assessing the degree of retraction, you also have to assess the quality of the clot, but you only have to do this after incubating the sample for 24 hours. So the clot may be stable or unstable after 24 hours. So for a stable clot, um, you would know that it is a stable clot, because if you're going to get the applicator stick with the attached clot and you roll it in a tissue paper, if there are no blood clots that will be present on the tissue paper, that means that the clot is stable or the clot is intact. However, if blood clots are present on the tissue paper, if you're going to roll the applicator stick with a clot, then that means that it is an unstable clot and the clot is not intact. Another method for clot retraction test is what we call the McFarlands method. So this is a semi-quantitative method, and in this procedure you are still going to collect blood using a red top tube that is made of glass, and then you have to place an applicator stick um, in the tube, and then you have to incubate the sample. So you have to also observe for clot retraction after the incubation period. So the clot that has attached to the rod is removed, and the serum that has remained inside the tube must be measured. Retraction is expressed in terms of the volume of serum obtained from the original volume of blood. So to be able to determine the percent serum or the amount of serum that has remained inside the test tube, you are going to use this formula in computing. So you have percent serum is equal to the volume of serum. By the way, when you measure the volume of the serum, you have to use the graduated cylinder. So the volume of the serum divided by the volume of whole blood, and then the answer to that will be multiplied by 100. So the reference range for this one is 44% to 64%. The whole process of clot retraction is dependent on the following factors. So first, we have the number of contractile platelets. We also have presence of calcium and ATP, normal concentration of fibrinogen in the plasma, and normal interaction of platelets with fibrinogen and fibrin. For the interpretation of the result for this test, normal clot retraction would be there would be presence of clot retraction between 2 to 4 hours. Poor retraction, clot retraction occurs after 4 hours and within 24 hours, and um, none or no retraction occurs after 24 hours. Abnormal result is found in patients with Glanzmann's thrombasthenia and thrombocytopenia if they have 100,000 platelets, less than 100,000 platelets per microliter. And that's it for your clot retraction and clot lysis test. Thank you so much for listening. If you have any questions, please feel free to ask your teacher. So have a good day, and see you next time.